Good afternoon, everyone. Thanks for being here for the continuation of our Stanford Health Day at the Expo. So, our next exciting group of speakers, we have this great panel of Stanford pediatricians and registered dietitians and physicians from our adult pediatric side and from the Allergy Center, Shah and Parker Allergy and Research Center at Stanford. So, I'm going to introduce each one and they can raise their hand. Dr. Nasim Khavari, Nielsen Fernandez-Becker, Andrea Gilbaugh, registered dietitian, and Neha Shah, registered dietitian, and Dr. Sindher from the Allergy Center. So we're going to kick this off. They're going to be discussing their myths. So they're going to address the topic, discuss that for about 5 minutes, then open it up for audience questions. We'll probably take 4 to 5 questions per myth. And then at the very end, if you all have other questions for the panel, we're just going to ask you to line up like we did with Dr. Green, and then we'll just pass the microphone down. So make it easier. So take it away.
Okay. Hello, everyone. Thank you for coming today. We're really excited to be here to share our wealth and knowledge with all of you. And we also welcome questions at the end to continue this discussion. Like she said, my name is Neha Shah, and I'm a dietitian on the adult side at Stanford Care, and I've been specializing in GI for the last 14 years. So I do definitely see a lot of patients in my own clinic that are diagnosed with celiac disease or with food allergies. Some of the questions I would like to share with you today are some of the questions that are coming from my own patients that they seek guidance on is something I will be reviewing today. So the first question is, if a restaurant offers a gluten-free menu, it means they know how to prepare the foods gluten-free. True or false? Good answer. Okay, that is a really good answer. So yes, a lot of restaurants may offer gluten-free options, or they may even have their own gluten-free menu, but the question lies on how they prepare those foods in their kitchen. And some of the suggestions I would offer my own patients is one, learning a little bit more on how those foods are prepared in the kitchen. Is it a separate area of the kitchen, or is there right next to the individual making that, particular food that may contain gluten? So another example I can throw out there is, there's a lot of gluten-free pizza that could be offered in a pizza restaurant, and I don't know whether those pizzas are made right next to each other or in a separate area, or maybe a gluten-free pizza could be made, but is it cut with the same cutter as the other pizzas? So these are questions that I would encourage, maybe not directly to the server, they may not always know, but talking to the manager or chef to learn a little bit more about their gluten-free practices in the kitchen to help you really know if these foods are gluten-free. Good answer. Okay, so the next question is, if the gluten-free food product says it's manufactured in a facility that also manufactures gluten-containing products, it's not safe for those with celiac disease. True or false? So it's give or take. The only way we're really going to know is if we contact the manufacturer directly to learn a little bit more on how they make those foods. If it's a shared equipment, then there's a high risk of cross-contamination there, and that's something I wouldn't recommend. Or maybe, these gluten-free foods are made in the same manufacturer that produces other foods with gluten. However, maybe they have a separate area as part of their plant that makes these foods. So again, ideally, yes, we want to choose foods that are certified gluten-free, dedicated plants to really reduce all the risk of cross-contamination and to make sure that food is gluten-free. But in real life, and coming across with a lot of my other patients, they may live in areas that they don't have access, to a lot of gluten-free foods in their grocery stores, or maybe or certified gluten-free availability in their area, or some of them might live in an area where believe it or not, there's limited internet access or along that line. So it's really just taking all precaution to reduce risk of cross-contamination and really learning a little bit more on how they produce that food. Okay. moving forward, the next question is, I don't have symptoms, so I can have a bit of gluten. True or false? That is true. So a lot of my own patients, they have come in, and the common question I get is, I don't feel anything. Do I still need to follow this diet 100%? Do I really need to be that strict with it? And the answer is always yes. Just because one may not feel symptoms, chances are your gut is still impacted by the ingestion of gluten, and we want to make sure your gut has all the opportunities out there to optimize the healing. The next question is, the gluten-free diet will help me lose weight. True or false? Yes. So with that said, that's a common question I get from my patients who are not diagnosed with celiac disease, but they want to explore this diet as a means to lose weight. And with any, being able to implement any strategies to lose weight, from my own personal experience, it really does involve portion control and increasing your physical activity, and really using your hunger versus fullness cues to help you guide you on how much you can handle and how much you can eat, versus focusing on special foods that may help you lose weight. And there's definitely strategies within those three categories that can help one lose weight. The last question is, the gluten-free diet is more natural than a diet that has gluten. True or false? That I can repeat the question. The gluten-free diet is more natural than a diet that has gluten. False? Yes. So within any diet, whether it's a gluten-free diet or a low sodium diet or a diabetic diet, we always want to encourage whole foods, natural foods, your fruits, your vegetables within the gluten-free diet, gluten-free whole grains, to really bring in the nutritionist quality of those foods. The term healthy to me is very vague. That has a different meaning to a lot of different people. I tend to use the term nutrient dense to really describe what we want to bring into the diet. So your fruits and vegetables, a natural source of vitamins, antioxidants, phytochemicals, low in calorie. Certainly the gluten-free whole grains can provide a source of fiber as well as other nutrition, low-fat dairy, your protein, your lean protein, your fish, your eggs. So that is really what wholesome diet is all about. The foods are more processed, whether it's the gluten-free processed foods or non-gluten. They may have added sugar, other aspects that may not make it as helpful. So really, at the end of the day, we want a food that has more whole foods as much as possible, so you can really bring in the nutritional quality of those foods. Okay, good job. You got 100%. Sorry. So foods labeled gluten-free are not always healthy, although some people believe that. In a person who can tolerate gluten, I have to say that, in a person who can tolerate gluten, whether or not a food has gluten doesn't make that food healthy or not. And actually, a lot of the processed gluten-free foods are lower in fiber, vitamins, and minerals than the gluten-containing foods that they replace. I'm not promoting intake of wheat flour, but I'm going to say that in the United States, wheat flour that is refined, or in other words, heavily processed, is then enriched with B vitamins and iron. Gluten-free flour may not be enriched. So what this means is sometimes when you change to a gluten-free diet, the overall dietary quality decreases. So disclaimer, clearly not every American is getting all the recommended amounts of nutrients. But on a gluten-free diet, when people follow a gluten-free diet, some studies have found that certain nutrients tend to be low if you're not careful. This may include iron, several B vitamins, calcium, phosphorus, and zinc. So gluten-free or not, it's important to make sure that you're making an effort for a healthy diet and getting all the nutrients you need.
Plant foods are especially important to any diet. As Neha said, they provide vitamins, minerals, fiber, antioxidant, all things that we need. So on a gluten-free diet, plant-based foods would be fruits and vegetables, nuts, seeds such as quinoa, and whole gluten-free grains such as millet, buckwheat, amaranth, whole corn, brown rice, wild rice, which I'll talk about in a minute, and gluten-free oats. If you're buying processed foods, one recommendation is to generally look for 2 grams or more of fiber per serving. And ideally, foods that are processed will have added vitamins, B vitamins, and iron. So, what's the deal with arsenic and rice? So, I'm sure most of you have heard a little bit of this. It's been in the news. If you haven't heard it, I don't mean to scare you. That's not my intent. But recently, there's been quite a bit of discussion about arsenic in food. Inorganic arsenic is specifically what we're worried about. It's a type of arsenic that's more toxic, and it's in some foods, especially rice. So I guess the rice plant is very good at sucking up the arsenic out of the soil. And unfortunately, much of our soil and our groundwater has inorganic arsenic from pesticides that have previously been used. So it's there. Long-term health effects associated with arsenic exposure, high amounts of it, are certain types of cancers and other health issues. So it's a big deal. And during pregnancy, infancy, and childhood, those periods are the most vulnerable. So one of the biggest concerns from a pediatric dietitian standpoint is arsenic in rice, and specifically arsenic in infant rice cereal. We found that there's about 5 times the amount of arsenic in infant rice cereal than the other cereals. So in this instance, rice may not be a better choice for an infant. You may want to make sure that you're doing other grains or other foods. The FDA just put out a proposed limit for arsenic in infant cereals, but they also put out this disclaimer saying that they recommend not to consume any one food in excess. So basically they don't want to say don't eat rice, but that's basically what they're saying is eat other foods so that you're not just eating rice. Eat other grains, eat other things, especially in children. So the last thing I'll talk about is dietary restrictions in children. You want to make sure that dietary restrictions are really necessary in children because they can be pretty problematic. They can affect quality of life, they can affect adequate calorie intake, which may then influence weight gain and growth. They can affect adequate vitamin and mineral intake. So ideally, any dietary restrictions in a child or an infant would be discussed with a healthcare provider.
Hello, everybody. I'm Sindher. I'm an allergist at Stanford, and I see both pediatric and adult patients. So a little bit of a change of topic, and we're going to talk about food allergies a little bit. Um, um, because even if you don't have food allergies, most of you probably know at least someone with food allergies. So the first myth is I have a food allergy because my skin and blood tests were positive. Is that true or false? False. Because a lot of times people are concerned about food allergies and they get panel testings for a lot of foods, and then things come up positive and they're concerned because, we've been eating this food. Should we stop eating it? And the answer is no. These testing are the methods that we have for testing right now, which is skin prick testing or lab work, are not perfect. They have a 50% false positive rate, which means half the time they're testing positive when it's not real. There's a very low false negative rate. So if it's negative, we believe it. But without a clinical history, a positive test does not mean anything. So unless you have a reaction to a specific food, you should not be getting tested for it. The second myth is if you have a food allergy, eating a little bit is okay. True or false? False. So the fact is, if you do have a true IgE mediated food allergy, even a little bit of exposure can trigger a severe anaphylactic reaction. So if you have food allergies, avoid that food at all costs. The third myth is EpiPens are dangerous and you really should avoid it and keep it as a last resort. True or false? False. Yes. EpiPens are the only medication that can actually stop an allergic reaction. Everything else, like Benadryl, Zyrtec, all of those are kind of just symptomatic management. They do not stop an allergic reaction. So when in doubt, use Epi. The only real side effect is that your heart will race a little bit and you might get jittery, but really that's it. The pros far outweigh the cons. So when in doubt, just use Epi. The fourth myth is peanut is the most dangerous food allergy, and even smelling peanuts can cause anaphylaxis. True or false? False. So, peanut is among the 8 most common allergens that cause the majority of food allergies, but it's not that one food allergy is more dangerous than the other. Everyone kind of has their own reaction to food. So, for one person who has a wheat allergy or peanut allergy, their wheat allergy might be more severe for them. And in terms of smelling, the protein that that leads to this aroma of peanut is not actually allergenic. However, if someone inhales an allergenic part of the peanut, it can cause anaphylaxis. However, it's very, very rare. And peanut is everywhere. So we really don't see that many people who are having reactions from inhaling it. So yes, those are it. Thank you.
So for those of you who heard Dr. Fernandez-Becker and I speak earlier, I'm sorry if there's a bit of overlap here in our midst. And feel free to ask additional questions later. Is it okay to try the gluten-free diet without doing any celiac testing? Raise your hand if you say yes. So, from a medical professional perspective, it's best to get your testing done before you start a gluten-free diet. And the reason why we say that is because some of your testing will falsely look normal for certain diseases like celiac disease if you've already been off of gluten. So you may miss out on what the actual diagnosis is. So that's why we always prefer to have you see a medical professional if you're having symptoms on gluten and let them help you make sure that we're not missing something else and that we can make the right diagnosis. Number 2, you always have gastrointestinal symptoms, belly pain, constipation, diarrhea, if you have celiac disease. False, that's right. There's actually a very large proportion of people, maybe greater than 50 or 60%, who have symptoms not at all related to the GI tract, but they still have celiac disease. And there's some people that have no symptoms at all and still have celiac disease. That's why we like to know if celiac disease is what's causing your symptoms so that we can screen your family members and other people for that early enough to prevent any complications. So that's one of the reasons why it's really important to get tested and know what it is that's causing your symptoms, or at least let us try. And number 3, celiac disease, wheat allergy, and gluten sensitivity are all the same. False. And I bet we're seeing a little bit of all of these diagnoses here today, right? Both in the audience and people who are here at this expo. And they're all diagnosed a bit differently. There's a huge overlap in symptoms between all 3 of them. But once again, if you eliminate one without talking to a healthcare professional, then we may not be able to differentiate them and help make sure that we're not missing complications from them, make sure that we're screening your family members if they need to be screened, and thinking about all the other aspects of it.
Okay, so number 4,
I tested positive for the celiac genes, or I got 23andMe, and it tells me I have the celiac genes. I must have celiac disease. True or false? So, how many of you think this is true? All right. So, yes, so the celiac disease genes, and this is referring to HLA, DQ2, and DQ8, only tell us about risk. About 40% of the population carry them, but only about 4 to 5% of people have it. So we don't use it in every patient. There are special circumstances where maybe things don't quite make sense, and we use it more to rule out the disease rather than rule it in. Okay, celiac disease is a rare disease. Nope. So we used to think the classic teaching a long time ago was, you're from Ireland, Caucasian, then you're more likely to have celiac disease. The reality is that we see it like that map that was shown this morning. We see it many different ethnicities. We are also better at picking up the diagnosis now, so that actually has probably accounts for more of the cases, but the prevalence is approaching 1%. And finally, wheat free is the same as gluten free. So I see you shaking your head. Correct. So gluten is in wheat, barley, and rye. So gluten free is wheat free, but wheat free is not gluten free. That makes sense. And now I'm going to throw out a few more. Because there was some overlap. So if you have celiac disease and you eat a little bit of wheat, will you have a life-threatening reaction? How many of you think you will? Okay. I'm sorry? Right. So let me rephrase that. So, right. So the mechanism with allergy and celiac is different. And the interesting thing in my practice is that some people have a really sensitive glutenometer, if you will. And they know the minute that I learned this from my patients, gluten. They know the minute that they get exposed to gluten. Yet there are other people, even when we diagnose them, that have absolutely no symptom at all, which is one of the things that I think is really interesting in the disease, why that is. But it also highlights the difference between allergy and celiac, because allergy triggers a life-threatening reaction because it could affect the mucous membranes, you can't breathe, whereas celiac disease is what we call cell-mediated. So it usually takes repeated exposures in most people in order for it to cause the damage. You also may experience symptoms. You could imagine if you've avoided gluten forever and all of a sudden you get exposed, your body's not used to it. And wheat has other carbohydrates that could also produce symptoms. And then the last one that I thought about that patients ask me is, if you're obese, you definitely don't have celiac disease. How many of you believe that's true? Okay. Yeah, so a lot of patients that I see have been told that. And the reason for that is because the teaching has always been that celiac disease, you have injury to the lining of the intestine and that you don't absorb nutrients. And that's true. But like Dr. Khavari noted, the manifestations are very different. In some people, most of the system that's affected is the skin or nervous system, less so the GI tract. And it could happen pretty much anywhere in the GI tract. So it is possible for someone to be very obese and have celiac disease, even before we treat them with a gluten-free diet. So I think that's all I've got, but we'd love to listen from you guys.
Maybe you can make a line with questions.
Yeah, and I also wanted to mention we partnered with the Celiac Community Foundation of Northern California. So they're so kindly, they've been videotaping our presentations today. Jennifer Iskell, the president, sitting right there. So these are going to be available on her website starting, Jennifer, when? Next week, maybe? I'm putting on the spot. Yeah. So give her a little time, but they will be on her website. You can pick up some more information at their booth right next to our Stanford booth. So that's why you can rewatch all this great information. So we'd love to take questions, and I'm sure you guys have lots. So do you mind lining up? That way we can just pass the mic down without running around. Yeah, come on up.
Hi. Not many people, or actually nobody's been able to figure out why, with my diabetes, type 1 diabetes, gluten makes my insulin completely resistant. Nobody can answer that. Can either of you?
The short answer is no. But I can tell you that there's a lot of research that we're trying to do to better understand that. And you're not alone, which I'm sure that you absolutely have figured out. You're alone. Oh, I guess, sorry, what I meant was that we have a lot of other people with type 1 diabetes who also have noticed that there's a relationship between them either getting, if they accidentally get gluten, then their blood sugar gets higher. Oftentimes, before their diagnosis of celiac disease, we see more episodes of hyperglycemia. So there's some way in which the two diseases definitely feed on each other. And you're probably familiar that there's a lot of shared genes, autoimmune diseases that share genes with celiac disease, type 1 diabetes being one of the main ones. And maybe you're familiar with the fact that there's a large prospective cohort study that's going on right now. It's actually looking at type 1 diabetics from birth onward, trying to look at their risk factors for type 1 diabetes, other autoimmune illnesses, and there's a huge cohort of them that we're also following with celiac disease. So your question will hopefully be answered with time, but I think what you're describing is definitely a known phenomenon. You can't check your serology, you mean, because your type 1 because your blood sugar is too high? Is that what you're saying? Yeah. Yeah.
We'll make this easier for everyone. So I will bring the mic out to you if that's more comfortable, so we can get everyone's question answered.
Okay, the arsenic question with the rice. The arsenic question with rice, is that also found in white rice, or is that mostly found in the husk of the brown rice?
It's all rice, but there's more arsenic in the bran. There's also ways to decrease arsenic in rice. So consumer reports and the FDA have recommended a specific preparation of rice where you cook it in more water than you need, and then you pour off the excess water. So you cook it in maybe, typically when you cook white rice, you would maybe triple the amount of water you would use, and you just would pour off that extra water. Where the rice comes from is important too. There's been more of the pesticide use in certain states in the United States. I probably would stick with California rice if I could. I would rinse the rice and I would cook it in more water than I needed, and I would alternate between brown and white rice. For adults, I think it's less concerning than in children. Overall, it's concerning. Our inorganic arsenic and the pesticide use, it's all concerning. But I think the impact we worry about more in small people than in adults. And Consumer Reports actually came out with a point system and different rice products and how much you could have per week. And it's not that you can't have rice, since you can't have brown rice. It's just to be thinking about ways to reduce the arsenic and not eating the rice at every meal every day.
Hi, my 7-year-old daughter has celiac disease, and her doctor has taken her through food sensitivity testing because she's still having stomach aches. And we have a gluten-free kitchen. We're all gluten-free. Like, we're pretty sure we're not getting major accidental glutening. But I was wondering how you feel about that, because it came back that she's sensitive to dairy and egg, and it's very difficult to cut out all these foods not knowing, are we healing her gut? Are we, if she has it once, are we getting in the way of her healing? So I'd just like to know your thoughts on that.
So with food allergy testing, it's kind so food allergy is a spectrum, I feel like, that varies with immediate IgE mediated reactions to some mixed reactions and then delayed kind of cell mediated type of reactions. And with the testing that's available, we're really just looking at IgE mediated reactions. So when it's positive, and like I said, 50% are false positive, it's not really assessing for sensitivity or celiac disease or intolerance. It's really just testing for if she eats this food, will she have immediate kind of difficulty breathing, eye swelling, lip swelling, vomiting, and needing epinephrine. So if that's never been the case, then it's most likely false positive. And the sensitivities that she's having, that is more of not an alert, like an allergy question, but more kind of a gastrointestinal question. And
Yeah. And I guess just to add to that, one thing that many people know is that when you have celiac disease, the lining of your intestine can oftentimes be inflamed, and and we call those the villi. And the tip of your villi have an enzyme called lactase, whose job is to break down milk. And so there's some percentage of the population is lactose intolerant, right? Unable to tolerate and gets those symptoms independent of celiac. But those with untreated celiac or maybe partially treated celiac could still have some secondary lactose intolerance. So I think that could be one part of it. I think the third aspect is there's some people that are just extra sensitive to gluten, and sometimes will recommend what's called the specific gluten contamination diet, which is extremely difficult. So I would say, as Andrea mentioned earlier, elimination is hard enough in a child. So then when you get to that form of elimination, you want to make sure you kind of ruled out and thought about other things. But that's sort of the next step that we would do if we felt like there was really no cross contamination. And then the other thing is that people that have celiac disease may have a slight increase in what's called bacterial overgrowth. So the bacteria that are sitting in the intestines may be in the wrong proportions to each other, the good bacteria and the bad bacteria. And so sometimes that can be a cause of persistent symptoms if you've already eliminated gluten and the symptoms persist. So those are some of the first things I would think about.
I just want to make a comment because this is food intolerance is incredibly common in the adult population, and my feeling is that we really don't understand what we're treating. If the tests that we rely on are blood tests, skin tests to pick up reactions, but the reality is that the small intestine or the GI tract in general houses our biggest immune organ. So it is an area of intense research, and it could be that there are reactions going on that we just don't have the right readout. We don't have the right diagnostic test yet, but I think that will come. And for now, unfortunately, we treat the conditions like what Dr. Khavari just mentioned. And there are certain foods. Someone tells me every time I eat avocado, I feel awful. Then we have to avoid it until we understand what the process is, so we could hopefully do something about it.
I have a little bit of a follow up to that. My kids and I all have celiac disease, and I'm wondering if we inadvertently get some cross contamination that does manifest in like a flare up from our immune system. What are the ramifications of that? Like, how long will our immune system be active doing damage to us from just say one or two small instances of cross contamination? I just don't understand like how big of an event that is if it happens.
Okay, so this morning we talked about how gluten causes injury, and basically for those of you that weren't here, it's it starts with the body misreading gluten as a potential pathogen or something bad, activates this immune response, and then you can imagine if your immune system thinks that you're being attacked by something and it's lining your small intestine, that's where the immune system is going to be activated. And this requires repeated exposure. So ideally, we want our patients to be gluten-free 100% of the time. But our society is such that every once in a while, we're probably, unfortunately, going to be contaminated. And the important thing is to try to avoid those. I think it's probably inevitable. It's probably going to happen every once in a while. But so long as it's not repeated exposure, we don't expect that it will result in permanent damage. And the small intestine, the GI tract in general, tends to heal fairly quickly. But we don't have the right answer as to how many exposures is the threshold that would culminate in something bad. For instance, like if over your lifetime you're exposed 10 times versus 20 times, we don't know. But what we know is that if you try not to avoid regular exposure, then you tend to heal.
Hi, I'm curious if in the adult celiac intolerance, if you are using the FODMAP more and more, and I have one that I've used for the last 5 years and seem to have not found anything more updated or reliable. Is FODMAP being utilized more with people that are you're seeing?
Okay, so in my practice, I often use a low FODMAP diet to counsel my patients. For those who have come in, and I guess I'll just throw out an example. If those that come in with the diagnosis of celiac disease, they've been on the gluten-free diet, they continue to have symptoms along the way, gas, bloating, GI distress, sense of urgency along the entire way, then my next step is to evaluate other intolerances in the diet. If one was diabetic, I can measure the blood sugars. If one has high cholesterol, I can measure the cholesterol levels. Tolerance to diet's a little tricky. I can't measure nausea through a blood test or any other GI symptoms. So I use FODMAPs often to help me rule out any other intolerances. And the way I approach it with my patients is one, is really assess what type of dairy comes into the diet, what type of fruits, what type of vegetables. If the questions are broad, I really want the details. What type of fruits, what type of veggies, what type of dairy, what type of how are you cooking your beans, and that helps me to really identify if the diet has other foods that could be potentially intolerated. And the second thing with FODMAPs, most of my patients have felt better being on a low FODMAP diet, and if they have not felt better, then it's really going back to portion sizes of the foods that are low FODMAP. There's a big difference of, eating, like I had a patient, maybe, I guess I can throw out an example, is I had a patient with celiac disease years ago, and she would come in with gas and bloating. She's been ruled out. They must have done multiple biopsies. And then she said something that apples and cherries make me bloat. And then I'm like, oh, let's look into fructose. And we end up doing a fructose breath test, and she has a fructose intolerance. So with her, we eliminated all foods with fructose. We treated it like an elimination diet, and then we added it back in. So even though like something like a pear is high FODMAP, and the whole pear just made her bloat, but 2 slices of a pear chopped up in a salad did not induce any symptoms. So I would have to say it's very dose dependent. So if one is still having symptoms, even while being on a low FODMAP diet, then my next step is to really evaluate how much is coming in at a meal. And that's really working with the registered dietitian to really understand how much is coming into a meal. There's no clear cut rules on what to take out. It's really working backwards, like collecting a food log and then really assessing how much is coming at one meal. Maybe it might help to subtract one food. Another example is I had a patient with celiac disease, constant bloating, and I had him do a food log, and I saw that he was eating quinoa, brown rice, and lentils all at the same meal mixed together. So I'm like, wow, okay, maybe that could be a possibility. So I had him switch to white rice, and either pick the quinoa or the lentil, and that significantly reduced the bloating. So it's just really more data collection to really learn a little bit more on what the potential food intolerances are. Potential. Everyone eats so differently. Yeah. Did I answer your question? Yes. Most definitely. I'm definitely utilizing the low FODMAP diet quite often in our practice. And I often use it either to place my patients on the diet, or I may use it to assess intake. Or if my patients who feel their GI symptoms are so distressing, it's just easier to avoid a lot of different foods in the diet. It's my way to add back foods as a transition to a regular diet. Did I answer your question as well? Okay, great.
Two quick questions, if I may. First one, steel cut oats, depending whether I look at WebMD or Mayo Clinic or somewhere else, they say they're fine or they say they're not. And then the second one is in a patient who has the food gene, and has had a negative endoscopy and a subsequent blood test. Is there still some portion of that population that is gluten intolerant, which one could test, I guess, by stopping gluten? Looks like a yes. Well, maybe we're good.
So oats may not be gluten-free. They may not be safe. Sometimes the crops are rotated, so you may have some cross-contamination there. You may have some cross-contamination when they use the trucks to carry the grains to the manufacturing place, and you may have some cross-contamination in the manufacturing. So if you want to be sure that your oats are gluten-free, they're certified gluten-free oats.
And then I think the second question was celiac disease versus non-celiac gluten sensitivity. So I want to make sure I understood the question. It was negative genes, or positive genes, negative endoscopy, negative blood tests. Okay. So one time point for blood tests is not a forever time point. So keep that in mind. However, if at the time of your endoscopy and at the time of your blood test, you were consuming gluten and enough gluten, which will usually say the equivalent of about 2 pieces of bread a day for ideally 2 months, then you did not have evidence of celiac disease at that time point. Your second question, which I'll let Nielsen answer more of, differentiates celiac disease from a common phenomenon, or we think more common phenomenon now, which is called non-celiac gluten sensitivity. So that's essentially a food sensitivity to gluten in particular, where people will have symptoms, but it's probably a different mechanism of action than celiac per se, which is what we're talking about here, but can still cause very similar symptoms. Sorry, I didn't hear the question. Oh, is there a test for non-celiac?
Okay. So my take on this. So you have the gene, so you're at risk. And we know celiac could develop at any time. So, but we can't predict if and when that will happen. Now, do we have a test for non-celiac gluten sensitivity? That would imply that we know precisely what it is. And so far, there's a lot of research, and it's probably different mechanisms at play. And we still don't have a consensus definition. And we don't have any biomarkers yet, so we can't tell you how prevalent it is. The studies that have been done suggest that there might be a situation where there is an immune mediated process. With celiac disease, we kind of understand the pathophysiology a little bit better, but we still don't know what the trigger is. So it might be that in a patient who has the genes, who has sensitivity to gluten, it might be a low grade immune response that we're not picking up yet. So no, we don't have a diagnostic test yet.
Can I add just one other thing? For the extremely motivated patient, which is very difficult, there is one paper, and I think it's more in pediatric patients than adult patients, but it suggested that what we could do for people who really wondered if they had non-celiac gluten sensitivity was a food log. So basically, it's a double-blinded food log where while you're consuming gluten for like I think it was like almost like a month or 2 month period of time, you fill out this food log, and then you do a crossover study. So you're on gluten and then off gluten, and then you can analyze that food log, and there's basically a somewhat systematic measurement tool to help you compare it, yes or no. It's very difficult to find people who are motivated enough to follow through with this, but right now, with the right population, that's sort of the best assessment tool we have.
We don't do that much in adults, but what the gold standard would be for someone to give you gluten and not gluten in a blinded way, like a capsule that has it, because obviously, if you know you're eating gluten, you might also, there's a placebo effect with that. So it's really difficult, and in the adult world, we don't do it much. Again, because there's not motivated.
What about the Cyrex lab? Is that Array 4? Array 4, gluten-associated cross-reactive foods and food sensitivity. Are you familiar with that? How do you feel about that?
I don't order it because it's difficult for me to interpret. I don't know what to do with the results. It hasn't been rigorously medically validated, so I don't rely on it. And if there's something there that it tells me that it's okay for you to consume, and you consume it and you feel terrible, I'm obviously going to tell you, please don't eat that. And so I don't use it in my practice.
Hi, yes. I had a couple of questions. One is that I was diagnosed with celiac disease about a year ago, and then I got pregnant and have a little baby girl. So I'm wondering if there's anything I can be doing. I've heard breastfeeding is very helpful for avoiding her developing celiac disease, but I'm wondering if there's anything else. I also managed to fall down the stairs not very hard and break my leg in 3 places. So I'm interested in whether or not there's links between celiac disease and like osteoporosis or bone weakness.
Those are great questions. So I'll start with we call it an at-risk infant. If they have a primary family member who has celiac disease, or if they have an autoimmune condition such as type 1 diabetes or otherwise, so are at higher risk for celiac disease. So between 1984 and 1996, there was what was called the Swedish epidemic of celiac disease, which maybe some people had heard about that, which there was about a 4-fold increase in celiac disease at that time in infants, up to about 3% of the population. And at that time, everybody did investigations and wondered, what is the cause of this? Is it because there's less breastfeeding going on? Is it because they started introduction of a cereal milk to infants at a younger age? And the short answer is nobody really knows, and breastfeeding is great. But to give you a little more data, after that, there was European recommendations that the at-risk infant should ideally get gluten between 4 and 7 months of age and while the mother is still breastfeeding, because perhaps that will be a window of tolerance when there will be less likelihood for them to get celiac in the future. A few years ago, there was a few randomized controlled trial studies done, so pretty vigorously done, that actually looked at that question of gluten introduction in a little bit more detail. And essentially what they found was that at least when you look at children up to 5 years of age and 7 years of age, there's probably no relationship to the timing of the introduction of gluten or whether or not it happens during breastfeeding. The recommendation that was made after that is that breastfeed for other reasons because it's good, but we can't make a comment about celiac disease. The one other finding from that study, though, which I think is relevant to your story, is that children who had a certain genotype or certain genes were more likely to get celiac disease at a younger age, and that if an infant is introduced gluten earlier and they're going to get celiac disease, the earlier introduction of gluten gives them celiac disease earlier. So it's still okay to introduce gluten, but just be mindful of watching for symptoms. And some people will elect to look for that specific genotype, although there's not official medical recommendations on that. Does that make sense? It would be worth thinking about. I'm always nervous to recommend genetic testing at this time because I don't know what insurance companies will do with that information down the line. And in the so in Europe, that would be the recommendation. Get genetic testing, and they have a different screening protocol than we do here in the United States. I think, I know, I mean, that's a whole different conversation. So, but I mean, I think the point is that that would potentially be something, and not all companies will cover your genetic testing. It's a few $100s usually out of pocket if they don't. The only other thing I'll say there's a lot of other things that are suspected to be risk factors for celiac disease. We're trying to understand them. We do think that probably certain infections will oftentimes precede celiac disease. There's not really a ton you can do other than make sure that your child gets the rotavirus vaccine and other things, right, to try to prevent those in the future.
Sorry. So regarding the bone density question, yes, with celiac disease, you could get decreased bone density, and that's malabsorbed because of, we think, in part at least, because of malabsorption of nutrients, including fat-soluble vitamins like vitamin D. So part of my practice is to obtain a bone density scan, and I'm pretty aggressive about sending patients to endocrinologists for treatment if there is decreased bone density.
Follow up, just to clarify. So if the at-risk infant is introduced to the food, the gluten, earlier than 4 months, is that a problem? And second, related to that, if it's an at-risk infant because of another relative, but the mother doesn't have celiac or gluten sensitivity and is eating gluten, does that cause any problem or make them more likely to develop symptoms they're going to get?
So it's usually we consider a first degree relative is what puts you at higher risk for celiac disease. And then in terms of earlier introduction of gluten, like less than 4 months of age, I would like actually Tina to make a comment about allergen introduction at an early age, because I think that in and of itself would probably be something worth mentioning here. In regards to celiac disease in general, probably not with the information that we have. It just means that if they're going to get celiac disease, the signs will probably show up sooner. And so we would know about it sooner, but there can be risks to introducing, like food allergy risk, to introducing foods too late. And so that's the reason why there's not a definitive yes, no answer to say don't introduce gluten, because we don't know what we may be doing to wheat allergy in the future if we stop children who are at risk from getting wheat earlier.
Regarding earlier introduction of allergens, some of you may have heard of the LEAP trial, which was which introduced Bamba peanut snacks earlier in children between 4 to 6 months of age, and they found that these children had a lower incidence of developing peanut allergy down the line. So they did more studies, and basically they've come up with the more variety of foods you eat at an early age, it helps you with your microbiome, and the more varied your microbiome is, the lesser your chance of developing allergies. Again, this is kind of the microbiome is something we're looking at. I mean, everyone's looking at right now for autoimmunity, diabetes, a lot of diseases, not just food allergy, but they do think that part of the reason food allergies and other allergic diseases are increasing are partly because of our microbiome getting more kind of less varied. So earlier introduction of many foods is recommended, at least from the allergic standpoint.
So 3 years ago, I was diagnosed with celiac, and I started to get these really bad sinus infections. So I was just wondering, how connected my celiac reactions and the immune system is.
So I'm not sure, but I don't think so. That's my answer. It's a great question. It's a good thing to think about. I would say make sure you see your primary doctor and have them think about and see if there's any other causes for your sinus infections. What I can tell you is that there's a small group of people with celiac disease that also have what's called an immunoglobulin A deficiency. So if you happen to have that particular immunoglobulin deficiency, a very small percentage of those patients are at slightly increased risk for certain types of infections. So that would be sort of one thing. But when they diagnosed you with celiac, they would have looked for that and probably told you. Otherwise, for all the various other manifestations of celiac disease that I've seen and read about, sinus infections is not a common one.
I just wanted to add to that. When someone has recurrent sinus infections, most common reason, I mean, they come to me because of immunological workup to see if they have immunodeficiency, and most of them don't. It's really because they have really bad allergies and nasal congestion. So when you don't drain like all the fluid that's in your sinus, it's the perfect place for bacteria and virus and fungal growth. So if you're having recurrent sinus infections, I would recommend either ENT or an allergy workup.
I've heard that there's a difference in rate of celiac between men and women. Is there more that we know about why that happens and how it presents differently between men and women?
So celiac disease classically has been more common in women, like other autoimmune diseases. Not 100% sure why. There's studies to suggest that it might be biologic. Other studies suggest also that women are more likely to seek care earlier. In terms of disease manifestations, there's really no gender differences that I know of. The disease itself, the manifestations are very varied. In some people, it's classic gastrointestinal symptoms. In other people, might be more extraintestinal symptoms. And I'm not aware of any studies that show that it's different for men and women.
But you are right, it is slightly more prevalent in women than men, as most autoimmune illnesses seem to be.
Can I say just a little something to clarification on the FODMAP? So just to clarify, we generally don't put everybody who has celiac disease on a gluten-free diet and a low FODMAP diet. The gluten-free diet should be adequate. But like we discussed this morning, some people have some lingering symptoms, at which point the low FODMAP diet can be helpful because of the intolerances. But the gluten-free diet is restrictive enough. We wouldn't want to restrict more if we really didn't have to.
So I think we're at our time now. So thank you, panel. That was terrific. And for additional questions, our team's going to be at our Stanford booth. So please feel free to come up and ask any questions. And then be back here at 3 o'clock if you can for Dr. Sindher's talk on food allergy and what helps or makes your food allergies worse. Thank you.